بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. هنكمل حالات الميتابوليك اسيدوزيس. النهارده عندنا حالتين مهمين. أول كيس هنبدأ بيها 86 years woman. This female presented to emerge with confusion, ataxia, and tachypnea with past medical history, perforated peptic ulcer, post-gastrogenostomy, and taking lactobacillus and mulberry juice like as a carbohydrate. And don't forget this patient 86 presented to emerge by confusion, ataxia, tachypnea, past medical history, perforated peptic ulcer, and she underwent to gastrogenostomy and taking lactobacillus and mulberry juice. On examination, she looks malnourished, blood pressure 180 over 96, respiratory rate 40, this is tachypnea, and temperature 36.8. Chest abdominal X-ray showed distended bowel loops. When we see a patient like this, you must put clear differential diagnosis from now in your mind. And her blood work came back by severe metabolic acidosis, pH 7.2 is low, and the BCO2 around 9.6 is low too, and bicarb around 3.9, all is low severe metabolic acidosis with anion gap 21, and the lactate little bit elevated, normal around 2. Just high anion gap metabolic acidosis till now. By this history now and this scenario for this patient was short bowel syndrome and dilated bowel, you should put differential diagnosis in your mind when you receive consult or when you ask it to see any patient like that. What is your diagnosis now? BH is severe acidemia, with bicarb is low severe metabolic acidosis, anion gap is around 21. When you calculate delta, we found less than 1. This was mixed anion gap was high anion gap metabolic acidosis, and lactate around 2.6, ketones negative. So not allelactic acidosis or ketoacidosis. Because ketone is negative and the lactate not too high, just not with allelactic acidosis. We know allelactate already divided to type A hypoxemic and type B with liver and metformin, and we have another type of D-lactic acidosis, D-lactate. These other differential diagnosis you should put in your mind. And the creatinine is high but not super high to do this acid-base disturbance, and then osmolar gap already. Osmolar gap is normal. What is left for this patient? Assay for D-lactate. You should do D-lactate when you saw history patient with a small bowel and the bowel dilated in X-ray and came by severe metabolic acidosis. Please don't forget D-lactate, found already 6.8 is high. There can be significant urine loss, perhaps account for mixed increase and normal anion gap metabolic acidosis. In this patient, you can see mixed high anion gap and normal anion gap metabolic acidosis. What is the mechanism for that? When we have short bowel or dilated bowel with this patient already who have malabsorption and receiving high carbohydrate diet, and this patient already with short small intestine or short bowel after bypass, and the glucose will be stay in the colon here, and will be fermentation will be happening inside this dilated colon, and this lead to organic acid production, overgrowth of acid resistance gram-negative anaerobes, just such as lactobacillus, the major D-lactate producer. When we have short bowel, with high carbohydrate diet, glucose will be fermented in this dilated colon and lead to organic acid production via this lactobacillus. This is a major D-lactate producer, and this D-lactate will go to the pathway to break down to pyruvate and glucose, and in the Krebs cycle, by ATPs and water, and by this small amount, because we have bunch here of this D-lactate, some of them will go to urine, and this will lead to normal anion gap metabolic acidosis too. This is just to summarize for this picture. Management of D-lactic acidosis, our patient now remove inciting agent like stop carbohydrate like mulberry juice, stop any carbohydrate source for this D-lactate, and more fermentation of this carbohydrate inside this dilated colon, and stop this novel bacteria like lactobacillus by using antibiotic, metronidazole, neomycin, or oral vancomycin to kill this bacteria that are responsible to produce this D-lactic acidosis. And we give boluses and maintenance no sodium bicarb for this patient. And don't forget antibiotic to kill this bacteria, either metronidazole, neomycin, vancomycin, all this done on an anaerobic organism. And hemodialysis, if your patient is severely shocked and hemodynamically unstable, you can start for him hemodialysis to remove this D-lactate and replace with bicarb during dialysis, will be better. Second case, real case, a 55-year-old woman with parotid gland adenocarcinoma. The patient was cancer now and receiving chemotherapy and admitted by febrile neutropenia. And he consulted us for next blood analysis, and we'll see. Already when taking the past medical history, we found here taking 4 grams per day acetaminophen. Most of the patient with cancer taking this for pain, and we found the Staph aureus bacteremia and started in her blood for this febrile neutropenia, started flucloxacillin. Now this patient taking acetaminophen 4 grams per day and the flucloxacillin. This is the key of our case now. This drug history will give us clue for our differential diagnosis. And the CNS already GCS around 10, blood pressure a little bit hypotensive and a little bit tachycardia. In hypotensive side and a little bit tachycardia and acetaminophen and the flucloxacillin. Here lab came by pH acidemia, BCO2 is low, and bicarb is low, severe metabolic acidosis, creatinine a little bit high, chloride also a little bit high. Whose albumin is low for this for corrected anion gap, don't forget that, and the osmolarity is too high, ketone negative, lactate is normal. Diagnosis, as we said, the pH is severe low acidemia, bicarb is low metabolic acidosis, and bicarb already fall from 24 around 18, and the BCO2 is appropriate around 16, from 24, and it's around appropriate compensation with an anion gap around 28, corrected anion gap before this low albumin 20 around 31. We'll go to osmolar gap already around 3. No osmolar gap already in our patient, just our diagnosis now severe high anion gap metabolic acidosis till now. And here is just diagram for her bicarb. Since normal bicarb is 30 over 5 days, she developed, she presented by bicarb around 5, this 5 days back. Acetaminophen or flucloxacillin, this is a clue of our case now. Just in normal glutamyl cycle pathway. Just to summarize this pathway, we have this glutathione to be formed. The glutathione amino acid, you need this 3 amino acid glutamate and cysteine and glycine. All this will share in formation of this glutathione, and this glutathione will by combining other amino acid and will be ended by cysteine and will end by this pyroglutamic acid, and by this enzyme 5-oxoprolinase will end it to form glutamate again. Okay, this is a normal pathway to form glutathione in normal person. You need this 3 amino acid, glutamate, cysteine, and glycine to form glutathione. And this glutathione will be break down to cysteine and this pyroglutamic acid 5-oxoproline, and will end it by glutamate. Okay, and this by this enzyme. Okay, if my patient taking high dose of paracetamol, acetaminophen, and this will do glutathione depletion, and this will inhibit this this amino acid here, inhibit the gamma glutamyl cysteine synthesis, and this lead to impair this glutathione metabolism to the pyroglutamate to glutamate. Okay, this is number 1, paracetamol toxicity, but he will end by high pyroglutamic acid formation here. And this is the first mechanism. And second mechanism, if we have inhibition for this pyroglutamic acid to be transferred to glutamate by this flucloxacillin, like our patient will inhibit this enzyme, and this lead to accumulate pyroglutamic acid, and this will lead to excess pyroglutamic acid. We have 2 mechanisms now: inhibition of glutathione formation by paracetamol will inhibit this gamma glutamyl cysteine synthesis from paracetamol overdose, And the second mechanism, flucloxacillin, will inhibit this 5-oxyproline enzyme, will lead to accumulation more pyroglutamic acidosis, and all this combined together will give you high anion gap metabolic acidosis. Diagnosis, high index of suspicion from past medical history. You should take good medical history for any patient with cancer like this. And to assay pyroglutamic acid, if you can do this pyroglutamic acid level, and stop any inciting agent like flucloxacillin, and acetaminophen. And this answers a clue for many exam questions. Don't forget this. And give your patient policies and maintenance sodium bicarb and hemodialysis as your assessment of your patient and the general status and the hemodynamics. You can start for him hemodialysis too. يبقى main treatment stop this agent flucloxacillin, acetaminophen. You can start sodium bicarb and then hemodialysis. And with our reference, and if you like to read any more details, ونسألكم الدعاء بالتوفيق والسداد. والسلام عليكم ورحمة الله وبركاته. ولا تنسوا الصلاة والسلام على حبيبنا محمد صلى الله عليه وسلم. ونلقاكم في فيديو قادم قريبا بإذن الله. نترككم في رعاية الله وحفظه. السلام عليكم ورحمة الله وبركاته.